So, guidelines. So we screen for unrecognised diabetes with an HbA1c at booking. Now, just to put it in context with all guidelines always write their level of evidence. So if you have a guideline that has an A next to a point, that means this is a randomised controlled trial. This is really good evidence, we must follow it. B, C, D, sort of expert opinion, and then you get down to good practice points, which is what most of our guidelines are in relation to gestational diabetes. Because interestingly, there's not a lot of evidence to say exactly what we should do. So the guidelines are there as a framework, but you might find at your different hospitals they're interpreted a little bit differently according to your patients or your women that you see, and according to your protocols. So just so I'll show you ours are a little bit different from what the national guidelines show. There's agreement that you refer if it's greater than 50. If it's 41 to 49, you carry on, it says we should give lifestyle advice. There's been a recent study about lifestyle advice in women with, they call it mild GDM. They've been diagnosed with low criteria, and showed that lifestyle advice does not improve pregnancy outcomes. And I think it's really important we give lifestyle advice to these women because they need it, but I don't know if that's going to fix their sugars, because normally it might improve them a bit, but normally when someone has pre-diabetes and you're trying outside of pregnancy and you're trying to normalise their sugars, part of improving their lifestyle is losing weight. And we don't want women in early pregnancy with an HbA1c of 41 to 49 to change their lifestyle and start losing weight. So I don't know if that's going to fix the problem. That's just my personal view on it. And then it says in the guidelines, request GTT at 24 to 28 weeks. And that's a little bit funny too, because we already know if their HbA1c is 41 or 49, they have abnormal sugars. In the second half of pregnancy, we know that insulin resistance is going to worsen their sugars. So why do a test to see if they have high sugars when we already know they have high tests? Again, that's my personal view on it. We also know that if you do a GTT and an HbA1c at somebody at the same time, one might be positive and one be negative. So the HbA1c will tell you they've got high sugars, but glucose is very variable in the lab, or it might be that the GTT isn't giving you as much glucose as you're eating and your sugars might be higher. So you might get a false negative GTT. Who knows the answer to that? And we know that in women who have an HbA1c of 41 to 49, we've published from our clinic that the women who come to clinic, that we have 90% of them on insulin by the time they're 20 weeks, because we choose to treat them early. But we also know if we don't treat them and do a GTT, only 80% of them will have an abnormal GTT. So 20% of women with an HbA1c of 41 to 49 in early pregnancy will never have any treatment for their high sugars. And as we all know, not everyone with GDM gets adverse outcomes, so you won't have adverse outcomes. And the other question, so that's one up in the air thing. The second thing is that people say it's okay to see these women, so some centres are seeing them. But quite rightly, people are saying, do you know at your centre, by treating them from 12 weeks, you're improving outcomes compared with centres who are only treating the ones that come to 24 and 28 weeks? And I'd like to say, yes, I am, but I can't prove that. So it's really important that studies are done. So in the interim, while studies are underway, you'll be at different centres doing slightly different things. And I think we just have to accept that while we're collecting the evidence. But if you're very worried about a specific woman, you might want to phone whoever you refer to or wherever you work, just to say, this is what's happening with this woman, do I need to do anything differently? So there is this trial sort of going on called the Pinto trial, and some of you might be aware of it. And women were initially, in Christchurch and in Auckland, women who had an HbA1c of 41 to 49 were randomised to either coming to clinic or saying, this is the lifestyle information and do a GTT at 24 to 28 weeks. But there was a lot of crossover. We couldn't keep the trial going because women read the information about we don't know which is better. So when I was saying to somebody at 14 weeks, your sugars, you've got 8s and 10s, I'd like to put you on insulin, they were saying, you told me in the information sheet it was okay just to do a GTT at 24 weeks. So no, thank you. I think I'll wait and do a GTT at 24 weeks. They come out the trial. And vice versa, women who, or their LMCs that were worried would get their women testing their sugars, and they'd be sent in even though they weren't supposed to be, and they'd be on insulin at 16 weeks even though they're in the lifestyle group. So now at our centre, we're routinely seeing them and collecting our data. Other centres are, and a lot of centres are not seeing this woman. And Ruth Hughes from Christchurch is trying to get the outcome data for all these women in New Zealand to see what the difference is. Preliminary data from very small numbers suggests early treatment might reduce the preterm birth rate, caesarean section rate, and preeclampsia rates. But too small numbers. So that's why we're comfortable to see them rather than not see them. We're saying, well, we may be benefiting these women. So that's just, I think it's important you all understand where the discussion is really around that now and how you think about it. Some centres have changed that 50 to say they'll see them when it's 46 or 47. There's all sorts of things going on out there. So you just need to keep in touch with what your local centre has recommended just now. Okay. And this is to put it in perspective. So this big triangle is all women with GDM. So you've got all women with GDM out there, and we've got to pick them all up. The top one is women who have undiagnosed diabetes, mostly type 2, but occasionally we'll pick up someone with type 1 in early pregnancy. And these are women with pre-diabetes, and that's the sort of ratio that you'll get. So in early pregnancy in other countries, they're actually using an early GTT, but no one has any idea what the cutoff is in early pregnancy. So they tend to use 7 or 11, which is the outside pregnancy GTT criteria. But they say, but if you're below that and you still have a diagnosis of GDM, even though it's the first trimester, they'll see you. So they see a lot of people from early on. We've decided we don't want to see everyone from early on, so we use an HbA1c, and this is what it is. So if we use, this is who we pick up. So if you have an HbA1c of 50, who's getting referred to clinic? 40% of our undiagnosed diabetes. So 60% of them have an HbA1c less than 50 in early pregnancy when they're looked at later. If we use 41, we pick up all the women with undiagnosed diabetes, and when we look postnatally, about 55-60% of them have an abnormal test postnatally. And we're looking at, which threshold, whether it should be lower, whether it should be higher, and that's still to be known. So we're in the second half of pregnancy now, and this is what is recommended at 24 to 28 weeks. If the HbA1c is 41 to 49, we've talked about that. Other women. Now the guidelines say do a 50 gram, you can either call it polycose or GCT, glucose challenge test, and then you do a glucose tolerance test if that is positive. But it does comment in the guideline pathways, because we made sure it was put in, that some centres don't recommend a routine 50 gram polycose, and they recommend 75 gram GDT if they're risk factors. You could make a case in New Zealand for all women having an OGTT because the prevalence of GDM is quite high, so all women have a significant risk of getting it. So that's what we were going to put in the guidelines, but sadly, from my point of view, that's not there. So we'll talk about a little bit about the polycose and what does it mean. So the polycose is not a diagnostic test, it's a screening test. And for all screening tests, they have to have what we call good sensitivity and specificity. So if the test is positive, you're saying it's picking up all the people that are going to have GDM. They all go on to have a glucose tolerance test. And also if it's negative, it means the woman doesn't have GDM. So it's got to be quite accurate, is the basic thing. So how accurate is a polycose test? So if you're doing a polycose someone, so who are you missing? Are you picking up the people who then go on to... If someone's got a negative polycose, does that mean they don't have GDM? No. So why do we do polycoses?
Find a reason to do it.
So
for women who are at low risk, do we need to go on with a 2-hour fasting?
yeah. So we're saying here that the 50-gram polycose is a good test for low-risk women who have a low chance of having GDM, and I think that's a very fair comment. Interestingly, when the guideline group met, the woman who is the consumer representative said, actually, I prefer to go to the lab once and have a diagnostic test. She said, everyone assumes it's easier for a woman to do a polycose than a GTT. She said, but I have to organise childcare for either test. I have to go to the lab for either 1 hour or 2 hours. And if I have a chance that I might have to go back again, I'd prefer just to do it. So I think it's, as you say, it may be very appropriate for low-risk women, but I also think it should be a discussion with the woman you're seeing as to the limitations of either test, as to what she might prefer. And also, again, I suppose, this is my personal view, I think it's quite a useful test, a GTT. It tells you where they are in that risk pathway. You know, does this woman have a fasting of 5.4 and a 2 hour of 8.8? You know, that's very different from someone who has a fasting of 4 and a 2 hour of 6 and things like that. One of the concerns about the 50-gram screen is that it misses women who are diagnosed with an elevated fasting test. And you're more likely to have an elevated fasting test if you have GDM if you're obese. So you're more likely to miss a higher risk GDM because 50 grams for a woman who's got an increased BMI, you tend not to get an elevation of the glucose 1 hour later. So you might be missing high-risk women, but I think you're not going to be missing your low-risk women the same way. So what are the stats? How many are we missing? If we look at, let's say at National Women's, where there are more than 6,000, but if I round it down to 6,000 deliveries, and we know our rate of GDM is about 10%, but some populations it's higher than that. So if we just say 10%, we've got about 700 women, but let's say we have 600 women in our clinic a year with GDM. If all the women had come through by doing a polycose and a GTT, we'd miss 20%, 25, 30% of those women. So out of the 600 women, 200 of them would not come to our clinic if everyone had a polycose. So, but if out of our 6,000 deliveries, the prevalence of GDM was 1 or 2%, let's say it's 1%, which is back in the day when the glucose challenge test was first devised, that would only be 60 women with GDM out of our whole service. And if you miss 20 women out of 60 women, out of a population of 6,000, 20 women is not so many women. So the test, where you decide what's reasonable for a test, also depends on the prevalence of the condition. And the higher the prevalence of the condition, there's no point doing a screening test, you might as well go on to the diagnostic test. And that's what we sort of do by our risk factor screening. We say, for that woman, you've got a very high risk and things. So at National Women's, we say, recommend 75-gram GDT first line if they have any risk factors or the woman has a preference. And 50-gram glucose challenge test is reasonable for a lower risk woman, although you'll still miss the odd one. So what are we doing? No one's mentioned HbA1c, thank goodness, for later screening. Why is an HbA1c no good for picking up GDM? And it's not to do with accuracy. So if you think about it, if you have normal sugars up to 20 weeks, your HbA1c is going to be 30, 32, right? Let's say at 20 weeks you start to increase your sugars. Your HbA1c might increase from 32 up to 34 or 35 over that 4 weeks. We can't diagnose GDM in everybody with an HbA1c of 32 or 34, can we? Because you're going to pick up a lot of normal people. So you need to have had significantly elevated glucose levels for quite a while before your HbA1c becomes abnormal. And even then, it might, if it's been low in early pregnancy because you've been normal, it's going to take quite a while. So it's no useful as a diagnostic test for GDM. It's called GDM when women are picked up in early pregnancy, sadly, but that's just a terminology problem. They don't really have GDM, they've got underlying glucose problems. So really, if you look at the average HbA1c in a clinic of women diagnosed with GDM, it's about 32 or 34. And if someone at diagnosis has an HbA1c of 41, 42, she's probably had high sugars for quite a long time. Now, We in New Zealand use these criteria for cut-off for GDM, which you'll all know, either a fasting of 5.5 or above or a 2 hour of 9. That's not based on any evidence, and that's what we've just used for a long time. So the big study that looked at all these women to look at their risks of having adverse pregnancy outcomes according to their GTT, you have the decision internationally is you've got a 75% increased risk of having a big baby, a caesarean section, a baby with a high cord C peptide, in other words, exposed to high sugars, or having hypoglycemia after birth, if your fasting glucose is 5.1, or your 1 hour, they do a 1 hour is 10, or your 2 hours 8.5. That's a 75% chance increase, and that's what internationally has been decided as a reasonable rate of complications to diagnose GDM. You've got a 100% increased risk. I mean, the risk might go from 10% to 20%. It doesn't mean you've got a 100% risk of, it's just an increase in risk of having problems if your fasting is 5.3, or I can't remember the 1 hour, or your 2 hours 9. So these are looking at different level of risks. So from the epidemiology, if we're going to stick with 2 hours of 9, because we're saying we can't afford to treat these slightly lower risk women, we should be using a 5.3 as a cutoff to fit with the evidence. But because ours has already been set in stone since 1991, what's happening is there's a trial underway comparing what we happen to have with the international recommendations to see if we should move to that. And that was agreed rather than moving one step and then possibly another step. That's the reason we're with this funny diagnostic criteria that doesn't fit with any of the literature in New Zealand. Australia's moved to the new criteria. Parts of America have moved to the new criteria. Europe's moved to the new criteria. Most Asian countries have moved to the new criteria. So we're a little bit different from other countries. Some have said we can't afford to look after all these women, and they're looking at 5.3 and 9. And it's all to do with where you draw the line. It doesn't mean you don't have a risk and you do have a risk. It's a continuum, and that's the problem. We do that all the time. Where do you draw the line with all women? So just a few things about management and postpartum to finish up with. So when women come to clinic, we try to explain to them we don't want you to have a label as such, and this is terrible. Our aim of diagnosing is to help you keep your pregnancy going normally and prevent problems. And we talk a lot about long-term issues. So we talk a lot about lifestyle. We ask them to measure their glucoses. We use metformin and insulin. Lots of other issues come with a GDM lady, we find, and talk about long-term. So, what glucose targets do we use? And most centres use something a little bit different. And then everyone gets really worried about having sugars that are lower in case it's too low. So this slide is to show you what's normal for pregnant women. So this is a normal population curve, and that line here is a distribution of sugars in normal pregnant women. And that's the 50th percent line. 85th centile, which is 1 standard deviation. You'll be aware of that standard deviations for the normal, and that's 2 standard deviations. And people tend to label something as abnormal when you're about here or occasionally here, depending on the condition. And these are blood sugars. So these are fasting, and these are not GTT results, they're just eating results from the start of eating your food, not from when you finish eating, but from the start of eating 1 hour later and 2 hours later. So the mean fasting glucose in pregnant women is 4 millimoles per litre. So 50% of pregnant women who don't have GDM have a fasting glucose less than 4. Now, if someone's on insulin, we like to sort of say, don't just sit on a blood sugar in the 3s, because they might be a bit lower or whatever. But if you're not on any medication or you're on metformin, a blood sugar in the high 3s is normal for pregnancy. And 1 hour after you eat is 6, and 2 hours is 5.4. So if you're diagnosing someone because we say their sugars are elevated, why treat to abnormal sugars? You might as well try to treat even to get them in the upper normal range. So in our clinic, we aim for the fastings to always be less than 5 if we can, and ideally nudge them down to the low 4s if we can manage to do that, but always less than 5. And if we use 1 hour, we say ideally less than 6, aim for the mid-5s, and always less than 6.5. We just round it to that number. And if they measure at 1 hour, less than 7, and all of them less than 7.5. And they're not absolute numbers. It's a reasonable guideline for women, because as you know, if any of you are looking after a woman with GDM, it's not a precise science. You don't go, oh, you've had a 7.6, I'm going to put you on insulin, or whatever. It's actually the pattern of it all. And if you give people a target, if you give them a higher target, they're not going to quite achieve that. If you give them a tight target, then you've got a little bit of room to manoeuvre. So that's what we use. The guidelines say a 2 hour less than 6.7, which is fine. We use, as I've said, R1s. Interestingly, we all agree that a fasting glucose less than 5 is what we should aim for, because there's good evidence to say that your pregnancy risks increase when your fasting's above 5. But we have this paradox still in New Zealand that we don't diagnose GDM unless it's 5.5. But we do see a lot of women in our clinics who come in with an elevated 2 hour test, so their fastings are less than 5. For those of you who, we have a system where they come to our clinic, women with GDM, but they're still under their LMC midwives. So our midwives outside of the clinic have a lot of it, seeing their women. We don't see them very much in our clinic. So if you're ever looking at their book, just remember that 60 or 70% of books do not match the meter. So you really need to know what the meter's saying. And the timing of the test as well. It's quite handy to see when they're doing the test and things. And in our service, and not all services do that, but in our clinic where we have a number of women who have impaired, glucoses for a long time, or undiagnosed type 2 because they've not been picked up, we do find the HbA1c useful at diagnosis, and we do one at 36, 37 weeks because that information helps us with their overall control deciding the time of delivery. And these are the obstetric issues. Our obstetricians are in our service see women at diagnosis, which is around 28 weeks usually when they come to the service, although as you all know it varies. And they tend to see them again at 36 or 37 weeks to discuss timing of delivery issues. I put weekly visits sooner. That's for general diabetes, our type 1s and type 2s. Our GDMs we tend not to see more frequently than other women. But if there are any concerns about poor control, hypertension, small baby, other things, we might see them more frequently, or they might be seen more frequently. The guidelines, I think everyone's sort of in agreement that you want to deliver by 40 weeks. We don't like them to go beyond their due date in general. Just being exposed to high sugars from the fetal point of view and the placental point of view, there are changes. The placenta's probably running out anyway. And even in low-risk women who don't have diabetes, the literature is now saying we should probably deliver everyone at 39 weeks. No one's going to do that, but that's actually what the studies show. Your best outcomes.
I think that's been discounted now for our population. The 39-week delivery. I think that was run in the States, that particular study.
Yeah, but I think it was a low-risk population. And the literature for women with an increased BMI is 38, 39 weeks as well. We don't do that, but I'm just saying that 41, 42 weeks is really going out the window for women and things. So we say 40 weeks for our women. But if they have other things, like they've got a huge baby or a tiny baby or terrible sugars or hypertension, or they're 45 years old or 47 years old, they often earn an earlier delivery. So about 60% of our women are induced, but our caesarean section rate is not increased in our hospital. I think probably everyone would do the same thing. None of our women have dextrose insulin infusions. That's sort of gone way by the by. Our only women who ever have dextrose insulin infusions are our type 1s, and again, a lot of them don't. They manage their sugars through labour, so it's very rare. We've moved from GTTs because they don't do them outside of pregnancy. And we do the HbA1c at 12 weeks postpartum. If you do it at 6 weeks, it's going to reflect their control in pregnancy still, and the fact that you're very insulin sensitive still for several weeks after delivery. Even at 12 weeks, it won't pick up all women who have diabetes because it tends to still read a bit lower than they will be. But it's a good time to do the test, and then they'll come back for annual screening. Initially, when we changed over at our hospital, the uptake in primary care was obviously lost in translation. Our follow-up rate was really poor, but in the last year, our follow-up rate's been about 75%. And there's some discussion as to whether we should have something in the Well Child book. You know, my mum had GDM. I think we've talked about this before, just to remind people to have a think about that. And these women get their diabetes early after they've had GDM, not in 10 or 20 years' time. They get it early. I've sort of talked about some of these things. For a lot of our women, I have a colleague who works with family planning, and she said, you must say this today, particularly if anyone from PHARMAC is here. Myrinas are the best contraception. You know, there are bigger women who get endometrial problems, and we used to put Myrinas in all of them. And now it's really hard to access them, and it's a real problem for us. But anyway, contraception in general is a big discussion. All our women have postnatal contraception plan as one of their items as soon as they come to clinic and things. So what happens after delivery time? Hopefully they go away with good messages back into the world. Now we know in Auckland of our GDM women, 25% of them have pre-diabetes or diabetes initially at their initial postnatal check. And the women who never go back are the women who often need to go back, so it's probably higher. And by 2 years, approximately 50% have pre-diabetes or diabetes. And when we did a follow-up study of our women from the metformin trial, and they were all women who needed medication in pregnancy, which is about 70% of our women, self-reported diabetes, not pre-diabetes, at 9 years of age, between 7 and 9 years of age, was over 40%. So that's diabetes. They're on medication. And they were the women who knew they had diabetes, so there'd be more than that who'd not been tested and things like that. So it's a significant problem. And if you happen to have an early HbA1c greater than 40, 55% of you will have abnormal tests at the 3 months postpartum. And hopefully that means we've treated some of them and they're, you know, actually, because if you have pre-diabetes, you can dip up and down back into the normal range for a while before you progress to your diabetes and things. And I think that's it from my point of view. They're all the thing I wanted to cover. So it's whether the